We have started discussing about the pathologies which are related to the liver, and in our previous lecture, we discussed about the liver trauma. Today, we'll be focusing more and discussing about the chronic liver disease. Although it's a kind of pathological process which is very chronic, and most of the time, it's a medical topic, and usually the patient is being managed on the lines of conservative treatment. But sometimes, because when the patient ends up in the end stages, which is called as the end stage chronic liver disease. So in that particular case, the only option left is the liver transplantation. So that's why it's important to discuss this topic, because some kinds of the shunts which have to be put in the patient for the drainage, like the transhepatic and surgical shunts, maybe for the good drainage of and ascites as well, and abdominal pelvic ascites. So we usually discuss this topic in the medicine, but the end stage chronic liver disease, the ultimate strategy, or you can say the management, is the liver transplantation, which is a surgical aspect. So we'll be talking this topic today. But for that, you should know or have a little bit idea about the liver anatomy. So we'll be discussing that at the first instance. So if we talk about the liver, it's a kind of the important organ which is located in the right hypochondrium. We know that we divide the abdomen in the 9 quadrants, and which is the right hypochondrium and the epigastrium, the left hypochondrium. Then you have the lumbar region, which is the right lumbar. Then you have the umbilical region, and then you have the left lumbar region. And the last, below the transpyloric plane, actually, they are the right iliac fossa, the hypogastrium, and the left iliac fossa. So out of these 9 compartments, the liver is enclosed, or it occupies usually the right hypochondrium, and sometimes the lobe of the liver is extending to the left or in the mid epigastrium. So if we could see particularly anatomy of this liver, so it's actually divided into 2 important lobes. One is the right lobe, and the other is the smaller one is the left lobe. As you could appreciate in this diagram, that this is actually the right lobe of the liver, which is much larger, and it's actually further divided into caudate lobe and the quadrate lobe. And the other, the smaller part, is the left lobe of the liver, and this is actually the falciform ligament, right? You can see that it's extending here at the center, and it's actually the falciform ligament is actually dividing the liver into right and the left lobe. And you can see here that the undersurface or the inferior surface of the liver has the gallbladder, which is adherent to the inferior surface of the liver. So actually, if we talk about the surfaces, it has got the anterior surface, the posterior surface, the upper surface or the superior surface. This is actually the superior surface or the superior pole of the liver, and this is the inferior pole or the inferior edge of the liver. So the superior pole is related to the costal margin, right? And the inferior lobe is just above the diaphragm. So whenever the gallbladder is actually irritating the diaphragm, the pain is actually referred to the shoulder. That's the reason, because the inferior lobe of the liver is actually in close contact with the diaphragm, and the superior surface is in contact with the costal margin. This is the anterior surface, and behind the anterior surface is the posterior surface, and on the posterior surface, posterior inferior surface specifically, there is the gallbladder, which is being adherent, which is being stick to the liver. So there are important peritoneal reflections, which are because it's important, because to connect the liver with the adjacent organs which are located in the abdominal cavity, right? So that's why there are some important peritoneal reflections and one of the important peritoneal reflection is this falciform ligament, which is extending from the superior surface to the inferior surface and actually dividing the liver into right and the left lobe. Other than that, you have other peritoneal reflections as well, which are the right triangular ligament and the left triangular ligament, right? So the right triangular ligament is attached to the right lobe of the liver, and the left is the left triangular ligament is attached to the left lobe of the liver. So if you could appreciate the surgical lobes, these wide it's important to divide the lobes because sometimes when you are doing the liver section, you actually do not do the complete hepatectomy. Sometimes you do the partial hepatectomy, which is also called as a lobectomy, right? So it's important you divide the liver into surgical lobes and the surgical zones. So this is the right lobe and this is the left lobe, and it's actually divided by the falciform ligament. Then this falciform ligament is extending in the middle. Another important thing is like you divide the liver into 8 important zones. Actually, if you could appreciate in this diagram that this is the inferior vena cava, the right hepatic, the left hepatic vein, the middle hepatic vein, and then these are actually entering into the portal vein, and by the portal vein it's entering into the IVC, right? So actually, the zone 1 is the posterior surface of the liver, so that's why you cannot appreciate in this diagram because it's the anterior view of the liver. So the posterior surface is the whole of the posterior surface is zone 1. Then this is the left lobe, and this is zone 2. The upper part of the left lobe is zone 2. The lower part of the left lobe is the zone 3, and this is actually in the middle is a zone 4. Then this is zone 5, this is zone 6, this is zone 7, and this is zone 8. Why? It's important to divide because it's important when you are surgically resecting the liver, so that's why it's important to divide this into the lobes. Now if we talk about the function of the liver, it's actually the process of the detoxification by the help of the portal vein, which is actually one is a portal circulation and other is a systemic circulation, right? So actually all the bloods from the whole of the inferior surface of the body that actually goes to the portal vein, it enters into the liver, it detoxifies the blood, and then the blood is drained into the inferior vena cava. So the important function of the liver is actually the detoxification. Not only the detoxification, but metabolism of the drugs as well. They have some important role to be carried out by the liver because the liver has got cytochrome P450 enzymes. So the cytochrome P450 enzymes, sometimes they are inhibitor to some drugs, and sometimes they are the stimulator to some drugs. So they're affecting the metabolism because most of the drugs, they're being metabolized in the liver. Then almost nitrogenous waste and everything, that's also being detoxified in the liver. Other than that, the formation of the clotting factors is very, very much important because the liver is playing important role in the synthesis of the clotting factors. So when you're assessing the function of the liver, or there's some kind of pathology with the liver and you need to check the status of the liver, you order for the coagulation profile, because whenever the coagulation profile is deranged, that means that the functional integrity of the liver has been compromised. So, because sometimes when the pathological process is not that widespread or is not involving a larger part of the liver, and it's limited to only smaller portion, so there is a compensatory functioning of the other parts of the liver other than the part where it is being affected. But sometimes when there's a generalized cirrhosis of the liver, the whole of the functional anatomy is deteriorated, then obviously there would be a derangement of the liver function. So that's why you order for some of the LFTs, which are actually showing the hepatocyte damage And now, why this is important to know? This is important to know because we order actually whenever you're assessing the liver pathology. One is a liver function test, and other is a coagulation profile. So liver function test, like it's the bilirubin, because it's also being metabolized in the liver. Then it's the ALT and the ALP as well, alkaline phosphatase, which is actually released from the gallbladder. And whenever the pathology was a gallbladder or in the ducts, the common bile duct and everything, so ALP is being made. But when there is a ALT is solely actually indicating the function of the liver, or you can say the hepatocyte damage, because liver is synthesizing the ALT, right? So whenever there's a hepatocyte damage, there would be a release of the ALT in the blood circulation that would be elevated. So it will be telling you about the damage to the liver parenchyma, and then the coagulation profile, which are important. PT, prothrombin time, PTTK, partial thromboplastin time, and INR status. These are actually the coagulation profiles which we send whenever you're assessing the functional anatomy or the functional capability of the liver. And whenever they're deranged, it's a confirmation that now hepatocyte damage is quite extensive and that it has compromised the function of the liver. So that's why it's important, and it's important to divide this into the surgical lobes. Now, if we talk about before going to talk about the chronic liver disease, you should have a bit of the idea about the circulation of the liver, right? So if we talk about the whole of the cascade of the liver, we actually know that liver is being supplied by two important artery in a vein, right? One is the portal vein, and the other is the hepatic artery. So almost 80% of the blood is being delivered to the liver by the portal vein, because obviously portal vein is actually the it carries the deoxygenated blood, but we all know that whole of the blood comes into the portal vein, it detoxifies in the liver, and then it goes to the IVC, right? So that's why almost 80% of the blood is through the portal vein, and the 20% is by the rest of the hepatic artery. We know that the abdominal aorta is actually giving the three ventral branches. At the level of T12, it's giving the celiac trunk, right? At the level of L1, it's giving the superior mesenteric artery. And at the level of L3, or lumbar vertebrae 3, it's actually giving the inferior mesenteric artery. I hope you're getting me that we have the abdominal aorta, which is located in the center, and it's giving off the branches. So if we talk about the ventral or the anterior branches of the abdominal aorta, so it's giving at the thoracic vertebral level, it's giving rise to the celiac trunk. Then at L1, it's giving rise to the superior mesenteric artery, and at the level of L3, which is the lumbar vertebrae 3, it's giving the inferior mesenteric artery, right? So the main part is with the celiac trunk, because celiac trunk then gives off three important branches, and the important branches are the left gastric artery and the common hepatic artery and the splenic artery. So the common hepatic artery actually is divided into right hepatic and the left hepatic artery. And obviously, the most of the supply is to the right hepatic. It's also giving the cystic artery, which is supplying the gallbladder. Now, the liver, if we talk about the liver parenchyma, so it's actually divided into acini and hepatocytes, right? And there are hepatic sinusoids, and actually these hepatic sinusoids, they combine together and they make the the right and the left hepatic artery, and then they combine together to form the right and the left hepatic duct, which combine together to form the common hepatic duct, and the common hepatic duct then combines with the cystic duct to form the bile duct. This is actually the common bile duct. This is actually important. Now, what happens to in the chronic liver disease? So before that, we'll talk about a little bit of the anatomy, the function of the liver, and the location and the blood supply of the liver. Now, if we talk about the chronic liver disease, what do you mean by the chronic liver disease? So, chronic means a process which is being going on, a pathological process which is being going on for a very long time. Whenever the disease process is extending beyond 6 months, we usually categorize this into the chronic. So, chronic liver disease means that there's some kind of pathology going on with the liver, and it's been extending for a very considerable time, like maybe more than 6 months, and sometimes the people present to you with a history of more than 6 years. So liver actually is occupying the right hypochondrium. So in the chronic liver disease, most of the time it is secondarily to the viral infections, the hepatitis, right? Because the hepatitis C and the hepatitis B, but particularly the hepatitis C, it actually sits in the bed of the liver, and it damages the hepatocytes, and ultimately there is a fibrosis of the liver, and the liver appears to be cirrhotic, which is actually nodular. So the nodular liver, sometimes in the initial stages, there's a kind of a compensation by the rest of the parts of the liver, but with the passage of time, it is in a decompensated state. And whenever the patient is in a decompensated phase or a decompensated state, because of that, a patient develops some kind of the clinical features which are related to the functional pathology of the liver or functional deterioration of the liver. Now, how if the patient is a chronic liver disease, is having a chronic liver disease, how it is actually going to present to you? So if we talk about the features of the chronic liver disease, the patient is actually lethargic, and sometimes there's a history of the fever, but sometimes the patient can be afebrile. There's a jaundice. Now, why there is a jaundice? Because actually there is the entire hepatic circulation which is going on, right? And we know that if we talk about the cycle of the bilirubin, so most of the time bilirubin is being produced. It's a kind of the metabolic product of the RBCs, right? So it's a kind of the you can say sometimes, like, we divide the jaundice into two causes, right? One can be the obstructive jaundice, and other can be the non-obstructive. So the non-obstructive is like the hemolytic jaundice. So whenever the patients who are that they are basically because they are chronic, they have the chronic liver disease. So in such kind of the patient presents with a jaundice. Now, why the patient present with a jaundice? Because actually the metabolism of the bilirubin is being carried out in the liver, right? So whenever there's a compromise in the liver function, obviously there would be decreased metabolism of the bilirubin, and the bilirubin then would be staying in the blood for a very long time, and it would be reflected as the jaundice. Then the patient has a protein catabolism, because liver has sometimes it has the anabolic effect, like, right? So liver is actually anabolic in nature, and it's actually producing the proteins from the amino acids. So whenever the functional part of the liver is being compromised, there would be protein catabolism, and because of that, the patient will have the wasting of the muscles. Coagulopathy, already being discussed. Why there's a coagulopathy? Because liver is synthesizing the clotting factors. So whenever the clotting factors are gone, obviously there would be a problem with the clotting of the blood, right? So there would be bruises, and there would be some kind of the the patches or the petechiae on the surface of the liver. Then hyperdynamic circulation. And in the advanced stages, the patient presents to you with a hepatic encephalopathy. Now, what do you mean by the hepatic encephalopathy? We know that the liver is important for the detoxification, and whenever there are a lot of the waste matter which are being produced in our body, right? And it comes to the liver, and it detoxifies those substances. But whenever the liver is gone, its functional part is gone, on, then these actually waste products, they start to accumulate in the body, and not only the other organs but also the brain. So whenever these nitrogenous waste products, they actually are pooling or being accumulated in the liver, in the brain, so the patient develops the hepatic encephalopathy, and patient presents to you in altered sensorium and irrelevant talk, and his GCS can be compromised. Now, portal hypertension. We know what do you mean by the portal hypertension? So it means that there is a kind of the hypertension which is related to the systemic circulation, and there's a kind of the hypertension which is related to portal hypertension. And now it's because of the dysfunction of the liver, and whenever there is a connection, there are some kind of the points in the body where there's a protosystemic shunts or the protosystemic anastomosis. Like if we talk about the lower end of the esophagus, there's a protosystemic anastomosis. And if we talk about the lower end of the anal canal, so at that point there's also the protosystemic anastomosis, and there's also the protosystemic anastomosis which is located in the abdomen, right? So one is a tributary in the protosystemic anastomosis, one is a tributary of the portal circulation, and the other is a tributary of the systemic circulation, right? So whenever there is a pressure, there is a kind of the pressure on the protosystemic circulation, and the patient may bleed. And because of that portal hypertension, the patient can develop the visceral bleeding, the patient can develop the PR bleeding because of the rupture of the hemorrhoids, because usually there's also protosystemic anastomosis which is located in the lower anal canal. Then if we talk about the appearance of the patient, there would be spider nevi on the anterior surface of the liver, on the abdominal surface, especially on the skin, because there are parenchymal veins. They are anastomosing with the other portal tributaries. So because of that, these important things can happen. Ascites. Now, because of the protein catabolism and the impaired function of the liver, the fluids start accumulating in the abdominal cavity, which is the ascites, and with the increased amount of the proteins. So the patient develops ascites as well. Then esophageal varices, which are very, very much common, and patient may bleed to death because of these esophageal varices. Then the patient might have the splenomegaly. Why splenomegaly? Because the part of the liver is affected, and as a result of that, there would be hypersplenism and the splenomegaly. Spider nevi, dilated tortuous, parenchymal veins, then pulmonary edema. These are the typical signs, and the tremors as well. So remember, the patient will typically present to you with the if we talk about the history, the patient would be lethargic, the patient will have the jaundice, patient may present with vomiting and altered sensorium, as if the patient is in the hepatic encephalopathy, or particularly to important things that need to be checked in the examination is like you would be checking the flapping tremors. You would ask the patient to keep the hands like this, and if there would be like this, that would be the flapping tremor. So these are particularly the important signs when you're assessing the hepatic encephalopathy in case of the chronic liver disease. Then the patient might present to you with the dilated parenchymal veins, and these are called as a spider nevi. There can be pulmonary edema, and the patient may present to you with esophageal and the hemorrhoidal bleed, but most commonly the patient present to you with the esophageal varices. Now, to quantify the severity of the disease, we have the CTP classifications, which is actually helping us to check out or to quantify the severity of the chronic liver disease, because the prognosis and the management of the patient depends on these things. So there are 5 important parameters we are actually going to be included in this CTP classification. One is the bilirubin, albumin level, ascites, encephalopathy, and the INR, which would be showing about the functional status of the liver. So if there is a bilirubin level less than 34, then you will assign 1 point to each. 1 point to this, right? And if the bilirubin level is ranging between 34 to 50, so you're going to award 2 points to this. And if the bilirubin level is greater than 50, then you are awarding 3 points to that. So obviously the severity is mild here, this is moderate, and this is severe. So if it is less than 34, the bilirubin levels are less than 34, there would be 1 point. The bilirubin levels are ranging between 34 to 50, there would be 2 points. If the bilirubin levels are greater than 50, then there would be 3 points. Now, next parameter in the CTP classification is the albumin level. So if the albumin is greater than 35, you will award 1 point to this. If the albumin level is ranging between 25 and 35, you will award 2 points to that. And if the albumin level falls more than that, less than 25, then you will award 3 points. Why the albumin level is being affected in this CLD? Because the liver is anabolic, and liver is important in the protein synthesis, and because of that, albumin is a protein, and if the liver function is being compromised, there would be decrease in the production of the albumin, and because of that, the patient will present with ascites. Now, if there is no ascites, you will award 1 point. If there is ascites, but that can be easily controlled with the help of the medicines or the diuretics, you will give 2 points to each. And if there is ascites which is poorly controlled, even with the drainage, the ascitic tap, then you will award 3 points to this. Now, encephalopathy, if there's no encephalopathy, then you will award 1 point. And if there is encephalopathy of grade 1 and 2, you will award 2 points. What do you mean by grade 1 and 2? Like it's the altered sense, it's not a complete unconscious state, but the patient is an altered sensorium and it is now well oriented, but he's still responsive. So that's grade 1 and grade 2. So the grade 3 and grade 4, you award 3 points each to that, and this is a state in which the patient is actually unconscious, or the GCS drops to 3. And then the INR, if the INR is less than 1.7, the point is 1. If the INR is ranging between 1.7 to 2.2, that means the liver function is slightly more deteriorated as compared to the previous stage, and you will award 2 points to this. And if it's greater than 2.2, you will award 3 points to that. So what are the 5 important parameters in the CTP classification? Bilirubin level, most important, then albumin level, then obviously the patient is developing the encephalopathy or not, the status of the ascites, and the INR ratio. So if the patient if the patient bilirubin level is less than 34, albumin is greater than 35, there are no ascites, no encephalopathy, and INR is less than 1.7, then the total points would be 1, 2, 3, 4, 5, right? So 5 points, that means the mild intensity, even if all the parameters are being present. Now, if we talk about the 2 points, so 2 and 2 and 2 and 2 and 10. So if the total comes out to be 10 or greater than 5, that actually means that the patient has got a moderate chronic liver disease. And if we talk about the severe chronic liver disease, obviously the count would be more than that, and it would be 15. It's somewhere between 10 and 15, right? So if it's greater than 15, it's greater than 10, or ranging between 10 and 50, the severity would be more, right? So this is important, the CTP classification, because it's actually helping you in the prognosis, and it's actually helping you to quantify the severity. So mild, moderate, severe, and remember the parameters: bilirubin level, albumin, ascites, encephalopathy, and the INR status is also important. Now, whenever you're investigating some kind of pathology with the liver, right? So what are the standard investigation you're going to order? So if we talk about the standard investigation, ultrasound is excellent marker, giving you the whole of the details about the liver. So the size of the liver, the parenchyma of the liver, the thickness of the liver, right? And any kind of the lesion which is being present in the liver, and the nodular or the status of the the liver can be well picked up by the ultrasound. So you can appreciate here in the center, this is the part of the liver which is being shown in this diagram, and these are the hepatic sinusoids which are being shown. And you can even ultrasound can also give you information about the status of the common bile duct, the diameter, especially if it's dilated or not, the presence of the calculi or the chronicity or the cirrhotic liver. So if it comes out to be cirrhotic nodular liver, then you will obviously think about the chronic liver disease. Now, CT and MRI, these are the two important investigation, but why you're actually if we have already said that if we're talking about the imaging of the liver, then ultrasound is sufficient. But sometimes to pick up the minute lesions, and when you're planning for the surgery, so the anatomical planning of the surgery would be by the CT and MRI, because you have to look for the zone. So it's actually telling you where the lesion is located. So this is the left lobe of the liver, and this is the right lobe of the liver, and it's dilated, and you can see that there is a lesion in the right lobe of the liver. So the MRI, it's also giving you more information about, because it's more informative in case of the pathologies related to the soft tissues. So it's kind of giving information about the right part of the liver. So the CT and MRI is actually helpful in the anatomical planning for the surgery. Now, there is another important investigation, which is the endoscopic retrocacal angiopancreatography. And this is important when you are imaging the biliary tract, because if the cause of the obstructive jaundice is somehow related to the stone, so ERCP is actually going to tell you about the caliber and particular location of the stone, or the caliber or the diameter of the CBD. So this is actually the endoscopic ultrasound can be used in the advanced cases. Now, there's another important investigation, which is the percutaneous transhepatic cholangiography, right? In endoscopic retrocacal cholangiography, you actually you're passing the endoscope orally and bypassing the stomach, and it enters into the biliary tree. But in case of the percutaneous transhepatic cholangiography, you actually go percutaneously through the skin from the right hypochondrium. You go through the liver, and then you are actually visualizing the because you know the hepatic duct is coming from the liver in the common hepatic, and this is the joint together to the common bile duct. So actually you go percutaneously, and you enter the part of the liver, and then you are actually visualizing the biliary tract. Now, if there is a vascular involvement by any kind of the tumor, then you can also go for the angiography. And obviously, if there is some kind of abnormality with the vascular channels, then you have to do the angioplasty as well whenever there's a vascular involvement by the tumor. When you are quantifying, especially when you're investigating a case of the tumor, these investigations actually, they are not related to the CLD, but just for the sake when you are quantifying the tumor spread, especially in case of the hepatocellular carcinomas, you want to know the status of the spread of the tumor. Then you go for the positron emission tomography, which is actually the PET scan. The PET scan is actually important. It's giving you kind of there would be emission of the positron waves, and because of that, there would be visualization of the metastatic part. So if this is the part of the liver, and these are the kidneys, the right and the left kidneys, right? So there's a large lesion which is in the right lobe of the liver, the inferior part, and these are the smaller metastatic lesions which are probably because of the hepatocellular carcinoma. It's involving both kidneys. So for those metastatic tumors, positron emission tomography is going to be helpful. And if you are trying to investigate the peritoneal spread of the tumor, then obviously you have to go for the laparoscopy, and by the help of the laparoscope, you can actually take the biopsy as well. Through laparoscopy, you actually give the 3 or 2 important sites of, as you can appreciate here in this diagram. One is for the grasper, and one is for the camera, and the other one as for the grasper or the scissor, whatever. So you can actually, if you are quantifying or you want to know about the peritoneal tumor spread, then you go for the laparoscopy. Now, what about but when you are dealing with the CLD, and then the ultrasound is giving you almost all of the investigation, whatever you need. And whenever you are planning for the surgery, then anatomical planning, where the lesion is actually present, how much of the cirrhotic liver is being involved, and if you want to do the partial appendectomy of the liver transplant, or you want to look for the zones, then you go for the CT and MRI. But usually, when you are trying to make a diagnosis of the chronic liver disease, only the ultrasound is sufficient. Now, the portal hypertension, because of the portal hypertension, because I have already discussed in a previous couple of slides that there's some kind of the portosystemic anastomosis all over in the body, right? In the lower end of the esophagus, in the anal canal, in the umbilical region, there are portosystemic anastomosis. So whenever the portal vein is important, because it has got the different tributaries which are actually hydrating the blood from the particular areas, and they're coming to the portal vein and is actually going to the liver, where it detoxifies the blood, and the blood is then going to the inferior vena cava. But in those cases in which the status of the liver, functional status of the liver is being compromised, then there would be pooling of the blood in the portal vein, and obviously there would be the portal blood will spill back to the systemic circulation. And whenever these shunts or kind of the anastomosis is present, there's dilatation of these portosystemic anastomosis, and because of that, varices developed, right? So in the lower part of the esophagus, the esophageal varices, they develop, and sometimes the patient may present to you with massive pure bleed, because hemorrhoids are also develop in case of the portal hypertension, right? So you could appreciate in this diagram that this is actually the abdominal aorta, and this is the inferior vena cava. So the portal vein is here, and the portal vein is actually draining the blood, and it's actually entering into the liver, it's detoxifying the blood, and it's coming ultimately, it's draining into the IVC. So portal hypertension is a kind of the complication whenever a patient has already developed a chronic liver disease. Now, the patient may present to you in the end-stage chronic liver disease. The patient present to you with a portal hypertension, and the manifestation of the portal hypertension can be a variceal bleed, can be a hemorrhoidal bleed, and hepatic encephalopathy as well. So the management of the variceal bleeding is very, very much important. Sometimes they can be conservatively. You have to start your management on the lines of the resuscitation, right? So the best thing to do in the immediate instant is to transfuse with the blood, because it's not good whenever the patient has already developed abdominal pelvic ascites. So it's not good to load the patient with a lot of the fluids. It's better you give the blood products. Correct the coagulopathy, transfuse the fresh frozen plasma, transfuse the FFPs, right? And sometimes if there is a need of transfusing the clotting factors, then you can transfuse the clotting factors as well. But usually, if the patient is bleeding, and because there is a bleeding because of the coagulopathy, right? So first transfuse the blood, and plus also you have to correct the coagulopathy as well, right? So for the correction of the coagulopathy, you have to give the FFPs. Then it's a kind of the not a conservative treatment, but the treatment which is which is usually done by the endoscopist or the gastroenterologist. So that is the balloon tamponade, esophageal balloon tamponade, which is usually done by the help of the endoscopy. But if you talk about the drug therapy, then you can also terlipressin. It's a kind of the important drug which is actually important in the controlling of the bleeding and also minimizing the pressure effects as well. Then endoscopic sclerotherapy or banding. Some people consider that in injection sclerotherapy, especially with the almond and phenol oil, if you're injecting that, so it's actually burn or sclerose that particular vein or the shunt which is being bleeding. But some people think that banding is the best option. You have to band the part which is bleeding. Then you have to assess the portal vein competency or patency as well, and you can also go for the jugular intrahepatic protosystemic shunts. They're also one of the option, and ultimately there are some surgical options available, including the liver transplantation. So if you talk about the esophageal balloon tamponade, this is the catheter which is being introduced orally, and it's being visualized in it has got a small kind of the camera along with it, and you introduce this catheter inside, and it has got a dial, it has got a balloon at its end, and you actually keep that balloon inflated right at the point where there's a visceral bleeding. So if you could appreciate, this is the part, the lower end of the esophagus, and at the lower end of the esophagus and the proximal part of the stomach, there is usually the protosystemic anastomosis, and you actually put the catheter and you dilate the balloon here, and it's actually giving a kind of the pressure effect to the point where it's actually bleeding. And usually the pressure you have to keep is like the 40 millimeters of mercury. And there are two kinds of the balloons, one the esophageal balloon and one the gastric balloon. So you actually inflate the gastric balloon with almost 300 ml of the air, and you keep the pressure of the esophageal balloon as 40. So the basic mechanism is to kind of generating a pressure effect, and because of that kind of the pressure effect is helping in controlling the bleeding. Okay, so there's another treatment, but it's again with the medical people, or it's again with the gastroenterologist, which is the endoscopic treatment of the varices. And you actually introduce endoscope orally, and you visualize the point which is being bleeding. Like you can appreciate here, these are the varices which are being bleeding. So there are two important things you can do endoscopically. One is the injection sclerotherapy, or the other is the that is bending. So most of the people prefer to apply the band instead of doing the injection sclerotherapy, because sometimes the bleeding is so much that the sclerotherapy fails. So it's important whenever the varices is present there, you just band it endoscopically. There's some kind of the other shunts, stent shunts, which are the transjugular intrahepatic protosystemic shunts. And as you could appreciate, that this is the part of the liver and the protosystemic circulation, and you go jugular, right? It means that you're entering through the internal jugular vein, and then you are actually reaching the part of the liver, and you are placing the shunt between the protosystemic circulation, right? So this is the portal circulation, this is the systemic circulation, and you are coming from the systemic circulation, and you're placing a shunt between, as you can appreciate here in this diagram, the part of the systemic circulation, the part of the portal circulation. You're coming through transjugular route, and you're going intrahepatically, and you're placing these protosystemic stent shunts, which are the transjugular stents. Now, sometimes these managements, if you're doing the banding or endoscopic injection sclerotherapy or esophageal balloon tamponade, then sometimes the bleeding is still not stopped, then you have to go for the surgical shunts for the variceal hemorrhage. And it's like you're opening the liver, and you're creating the shunts. This is the part of the stomach, this is the spleen, and these are actually the splenic artery, which is going here, right, coming from the celiac trunk. So these are the kind of the, as you could appreciate here in this diagram, this is the normal anatomy, and these are the portosystemic shunts, right? So this is actually the portal vein, and you are creating the portosystemic shunts here. So that's how they can be performed. But this is a shunt which is being put into the portosystemic circulation surgically, and the open method is being adopted. You give them a line incision, you go through that. Sometimes the people prefer to go give a kind of the transfers or the subcostal incision. They expose that particular area, and the shunt is being placed, which is actually work which is being given by the vascular surgeons. There's some other causes of the variceal bleeding, not only the CLD or the portal hypertension. If the causes of the variceal bleeding is widespread thrombosis, then ultimately the patient has to end up with a splenectomy or the esophageal devascularization, because it becomes difficult to control the bleeding, and you have to ultimately you have to do the gastroesophageal devascularization, or ultimately you have to do the splenectomy. Now if we talk about the ultimate management for the variceal bleeding, or for the end stage liver disease, and that is the liver transplantation, which was initially very difficult, but with the progress and with the more advancement in the compatibility between the recipient and the donor, this is quite possible that liver is being transplanted into the recipient, right, or the patient with a chronic liver disease, and it's being widely practiced in the European countries as well, in USA, Africa, UK, and even in India. So it's a kind of the but for that there are some kind of the prerequisites which need to be followed: the HLA typing, the blood grouping, and the compatibility between the recipient and the donor. Because if there's not a good compatibility between the recipient and the donor, and ultimately there would be liver rejection, and the patient will go into the antibody mediated rejection. So that's how it's important when you are going for such kind of the transplantation, the proper coagulation profile, the antibodies, and testing for the immunotyping and everything, immunohistotyping. That's also important to go in. And in case of the patient, ultimately the only option for the end-stage chronic liver disease is the CLD. But those patients who have already developed the portal hypertension, variceal bleeding, they ultimately, if the bleeding is massive, or there's hepatic encephalopathy, then the patient ultimately dies because of these complications. Now, one of the complications of the chronic liver disease is ascites. So actually, and with you could appreciate in the diagrams the massive abdominal distension, right? And there are the important veins which are being promenaded: the caput medusae and the spider nevi, right? This is the spider nevi, and this is the caput medusae. So these are the dilated parenchymal veins because of the portal hypertension, right? So if we talk about the determining the cause, it's important to know why the patient has developed ascites. It can be because of the CLD. It can be because of some malignant conditions or malignant tumors which are already metastasized to the peritoneal cavity, right? So if you are determining the cause, first of all, the imaging modalities you would be needing would be ultrasound or CT. So if there is an irregular cirrhotic liver in the ultrasound or the CT, then obviously you'll think about the chronic liver disease. You have to check for the portal vein patency as well. You need to check for the splenomegaly of cirrhosis. If you are trying to determine the cause, the imaging and the aspiration, these are the two important things which you need for determining the cause. If you're ordering for the ultrasound and the CT, and there's a irregular cirrhotic liver, there's a portal vein patency is compromised, or there's a splenomegaly of cirrhosis, then you'll think probably about the chronic liver disease. And aspiration and then sending it to culture and microscopy, the protein content, and cytology. These are important investigation. You need to go for the aspiration cytology because in some kind of the CAs like the gastric carcinoma or the ovarian carcinoma, they spread to the peritoneal cavity. There's a seeding, and because of the seeding of the malignant cells into the abdominopelvic cavity, there is ascites as well. So that's it's important to send these to take the aspirate, to do the pleural tap, cytic tap, and then send this for the routine examination for the protein LDH content to see if it's exudative or transudative. And then obviously you need to go for the culture in the microscopy, and you need to go for the cytology, and you need to check for the malaise level as well. So talking about the treatment in the CLD, first of all, important thing is like you have to manage the patient conservatively, and salt restriction is important. Diuretics, first of all, if there's not a massive ascites, and you can control with the diuretics, and diuretics actually help to get rid of the excess water, right? So the diuretics and salt restriction, usually they're the first line strategies in the initial stages, but in the later or the advanced stages, you have to do the tap or the paracentesis, like draining the fluid, and transhepatic intrajugular transhepatic intrajugular stenting is also one of the possibility, because you place that stent there, and because of that stent, there is a drainage of the fluid which is being present in the abdominopelvic cavity, and ultimately at the end the only option you're left with the liver transplantation. So if we talk about the abdominal paracentesis, actually what you do is you insert the needle, you first of all you percuss, and the point where there's a maximum dullness is being present, then you insert the cannula or the needle through that point, and it is right behind it. It is connected with a tube and also the suction. So you do the abdominal paracentesis like this. Keep the patient in a supine position, percuss the maximum point of dullness, insert the needle from that point, and this drain is actually draining, and the suction is applied to one end. Now, already discussed about the transjugular intrahepatic portosystemic stents. They're also used, and again, this is the systemic circulation. This is portal circulation. It's actually draining the portal vein is draining to the jugular. Through this way, it's a kind of a bypassing the portal circulation, and ultimately the ultimate management for the chronic liver disease end stage patient is the liver transplantation, which is already being discussed. And what you need to do is you need to expose a good exposure, good mobilization, and you have to cut the important peritoneal reflections and the ligaments, right? The right triangle ligament, left triangle ligament, and the falciform ligament to mobilize the liver, get the control of the vasculature, and remove the liver and the other liver after the compatibility and everything. You will transplant it, and the post-operative care is given accordingly, and you have to give immunosuppressive drugs for a very long time, just in case of just like the kidney transplantation, so that rejection can be avoided for a very long time. So this was about today's lecture. We tried to discuss about the chronic liver disease, the manifestation, the conservative and the non-conservative and surgical intervention which are being required to control this disease. So thank you for watching sqadia.com.